On this episode of the Ask Mike Reinold Show, we talk about incorporating both isolated and functional strength training into one program. We talk about how we communicate and collaborate between fitness and physical therapy at our facility and some recommendations for you. And lastly, we talk about the first rib and whether or not it can actually elevate.
The Ask Mike Reinold Show. Helping people feel better, move better, and perform better.
Welcome back, everybody, to the latest episode of the Ask Mike Reinold Show. I'm up at Champion PT and Performance up in Boston, Mass. We have another good collection of our PTs and strength coaches for another great episode. We have Dewesh Podell, we have Christy Zermulin, Nick Esposito, Dan Pope, Dave Tilley is not with us, Lenny McCreen is not with us. I feel like we have to, like in memory, we have to add them. Mike Scudito and Kiefer Lammy. So everybody's here kind of answering some questions. We've got a nice variety of questions for you again. Our students here, again, from the University of Utah, Matt Berserkenstock,
I think that's perfect.
Berserkenstock.
Yeah.
I like Berserkenstock
Keep
the
it.
best. Berserkenstock from yeah, we already went through that. And Hailstorm Haley Brinkman from the University of North Dakota. Take it away, guys. Let's get another great episode.
All right, we got Kobe from LA.
Kobe from LA. This is the second time we've had Kobe from LA. He's like, if you have patellar tendonitis, would you recommend Europe for stem cell? So, do you guys think this is Kobe from LA, or do you think it's Kobe from like Louisiana?
I think it's the real Kobe.
Kobe?
I like to think it's the real one.
Definitely, right?
Kobe being Bryant.
All right, Kobe being Bryant. All right, Kobe, what do we got?
All right, the seated knee extension machine gets a lot of flack for not being functional. However, in knee injuries, wouldn't it be helpful for restoring and encouraging knee extension? Also, do you guys use it during ACL rehab?
All right, good question. So, open kinetic chain, we'll kind of break this down to there's lots of mini questions here. Open kinetic chain knee extension, an isolated strengthening exercise, gets a lot of heat for not being functional. Why don't we talk about that for a second a little bit, is, you know, if somebody's post-op or post-injury or something like that, they actually have a deficit in strength, is it okay to do isolated strengthening? What's that? Dan, you want to start from the PT perspective, maybe?
Oh, I think this is interesting too, and I maybe had a weird bias going into as a physical therapist in a PT school, because I was a strength coach for a while, where we all poo-poo on an exercise like it's really stupid. It's probably one of the most evidence-based knee pain exercises out there, right? There's a lot of evidence to show it's effective for knee pain. So yeah, I don't use it a ton personally, but I can definitely see where it fits into a rehab program. It's definitely a good option if you need some strength in the quad.
Yeah,
For sure.
Yeah, we used to have a knee extension machine at some of my past places, and we used it all the time with our patients. Right? It's I think restoring your strength if you're weak is quite functional, right? You know, when you think of it that way. But what do you, maybe strength coach perspective? I don't know who wants to jump in. What do you guys think about? You know, where's the, you know, where do we put in isolated strengthening versus just function? Like, is there, you know, where's that blend? I don't know. Kiefer, you want to jump on that one?
Sure. I mean, I think from a strength and conditioning standpoint, kind of like your squats and lunges are always going to take like a bulk of the priority as far as strengthening goes, but especially speaking from my own experience with somebody that just came back from a knee injury, it's pretty hard to mimic the difficulty that you can get from an open chain exercise near end range knee extension there. So for that, I found that it was super helpful as an accessory movement for me to help build back some hypertrophy, as well as kind of like strength and comfort in different ranges.
I like that, yeah. And look, if you just rely on, you know, squats, deadlifts, stuff like that, that's, you know, double leg type things. I mean, if you have a weak link on one side, you're probably going to compensate a little bit, right? So, yeah, what do you guys think? Nick, Christy, what do you guys think? I don't know.
I mean, I think I don't have, obviously, experience, I guess, working with people coming from, or this close, like where maybe we're working with people that are coming out of physical therapy, you know, in the strength side of things. I feel like I would hope that doing functional stuff like squatting, lunging, deadlifting, I would hope people would be able to kind of start doing some of those exercises coming out of PT, and maybe isolated stuff is more your guys' kind
Right.
of field.
Sure, yeah.
That's just my.
And we do that quite a bit. If you look at our strength and conditioning and kind of like our system of how we do things, like we work on isolated weakness quite a bit with isolated exercises, right? But then we integrate it with functional exercises as well, right? So this is like one of those typical like, type of questions, right? What's better, like isolated strengthening versus functional strengthening? And I think it's just going to come down to always like, why do we have to choose, right? Why don't we just put them both together and let's do them together? And that's really how we do it. If you're ignoring a weakness and you're just going straight to like a lunge, for example, or two-leg squat or something like that, you're definitely going to limit the amount of strength you could potentially get with that. I'm pretty sure the knee extension exercise is one of the best exercises to strengthen and hypertrophy your knee, right? So if you look at it, right, like it's a great exercise. So we do it post-op, and there's some old school restrictions like 90 to 40 with the ACLs that I think you could argue the biomechanical literature is doesn't show it as much, but we do it post-op, and then we try to progress. And I don't know, I wouldn't fear it, I guess. Don't choose between functional or strength. If somebody has isolated weakness, you can isolate and strengthen. That's kind of how we do it. So nice. What's next?
All right, we have Kenny from Spokane, Washington. Hey everyone, after a patient has reached your criteria for discharge, how do you communicate with fitness professionals outside of your facility about the patient's needs? He's also offering bonus points for addressing privacy.
Ooh, we gave bonus points for privacy. All right, so PTs, this is more. So PTs, how do we communicate? Well, not outside, but inside. Or how do we communicate to our coaches? And then maybe from the coaches, why don't you give us some tips that you would like to know from PTs? Maybe like what info would you want to know? But what do we do? How do we guys do it here? You want to take this one, Mike?
How do we communicate with coaches?
Yeah, or so somebody's transitioning from
With
PT
strength
to
coaches
fitness.
or
Yeah,
different types
strength
of
coaches. Yeah,
Okay.
fitness people.
I think what we do really well here is when we feel like a client's ready to get out into the gym. We have a couple different options, but one thing we can do is we write a joint program together with the strength coaches. So I've sat down with Kiefer a couple times, and he's asked me questions, I've asked him questions, and we've kind of come up with our joint opinion on what this person could be doing in the gym, something like that. If you don't have that luxury, I think, I won't speak for Dan, but I think he makes a lot of Google Docs with his patients.
Well, I guess one of the big things that we do is I try not to take people away from the things that they love unless they absolutely need to. So from a fitness perspective, I see a ton of people that like, let's say CrossFit or Olympic weightlifting or powerlifting. The last thing they want me to tell them is I need you to stop what you're doing, right?
Right.
So one of the absolute biggest things that I do is I try to continue with their training in a way that doesn't hurt them further and they can make progress over the course of time. A lot of these individuals are working with coaches, so a lot of times in-house. So if someone comes in, they're already training at Champion, right? And then they come in because they've gotten hurt. What we do is we do an evaluation, we figure out what's going on, and we kind of figure out if they need a lot more physical therapy, if we need to back off a little bit more from the training perspective, or if they can continue with modifications. What I do specifically with a lot of CrossFit coaches, I have a Google Doc, and I basically have all the exercises listed out that may occur in a CrossFit class. We rank these on a scale of 0 to 10, right? And if it's below about 8 out of 10, we say we need to modify these. These are modifications. So what happens is that when the person goes to the CrossFit box, they're not necessarily harming themselves further by doing too much. They have modifications. The coaches know exactly what's good and what's not. And I put like a little kind of love notes here, like make sure hips go back and knees are, whatever. But I just make sure that we modify appropriately and we continue having them exercise as much as possible. That's the same thing I think we do here. We work together and it's one integrated unit. It's not like, okay, you're done your rehab, now you go fitness. We try to keep it going.
I like it. So collaborate, talk about some things like, hey, focus on these areas. And that's how I try to say it when I talk to coaches, is focus on these areas. I don't say, hey, this is how you do your job. I'd say, focus on this. I need them to get more agility work. I need them to get more power, right? And versus do this exercise. Because then there's, you want the expertise of the person that is writing the program to actually come out into your program. So it's collaborate a little bit, right? And make sure you have an open mind. One thing I'd say from the PT perspective is an outside kind of place and you don't have that relationship with the person. Sometimes what I'll do is I'll just disseminate the information to the person and just say, here's my recommendations. I'd say, here's what you're currently dealing with. Here's my recommendations on areas of focus and areas to avoid. And I'll give that to them and I'll let them disseminate the information how they please. Because sometimes sometimes people just don't want to be told what to do, right? But if it's coming from, the patient, the client, and they literally say like, hey, here's the things that I need to work on, I think sometimes it works. But I would definitely say, hey, tell your coach, your personal trainer to call me though. I'd love to talk about it. So coaching wise, quickly, what do you guys think? Like, what's some information that you want to know from the PT perspective?
Yeah, I think one of the bigger things that I've seen, like especially in my short time here working with the PTs, is their ability. I mean, they've been working with them in the physical therapy setting, so they kind of have a better understanding of how that person might perceive an exercise, or they might learn an exercise. So that'd be good to know, whether they're visual, whether they're more, they need kinesthetic awareness, they need something to, help learn a different exercise out there. So as we start programming newer things, we can have a better understanding of how they're going to relate those exercises.
That's great. Yeah, you even know them as a person, right?
Yeah.
How as a person they're gonna like, hey, this isn't gonna be an exercise that they jive with. I like that. What do you got, Christy?
I would say, I mean, it's just a collaboration the whole time. I feel like if, we can learn from you guys what people might need in terms of, a movement standpoint, like what they need to move functionally, where their deficiencies are. And I think collaborating, starting in here and bringing it out there, I don't think it gets better than that. I think we're lucky in that sense that we have you guys right here. So just using that.
So lucky. Nice. Dewesh, what do you think? Like, I mean, you've been here, a lot longer. Like, what's the information that you get from us that you think's impactful?
Yeah, I mean, I think it's like the constant updates as far as how the patient's progressing through their rehab process. To work with a couple post-op patients, so just kind of knowing how far along they are and how well they're improving in here to kind of base some of my programming out there is definitely helpful.
I like that. So that's a good addition to collaboration is then continuous collaboration and communication. I think that's actually a really good one too. I like that. Kiefer, you got anything to add? I know we had a lot of great stuff.
No, I would agree. Just kind of piggybacking off of him, it's knowing where they've been with you guys, what we can continue to progress, and what might be limited, and then we're lucky here, but having the opportunity to continually talk with you guys, whether it's every 2 weeks, every 4 weeks, to say all right, they did great with this, what's our next step here, or hey, they were having some pain with this, how can I maybe modify this or back it off? And I think that's super important.
I like that. Yeah, just have a conversation. I think that's the way to go. So, and I will take a stab on the bonus points, right? We had some bonus points for privacy. Just ask the person, hey, do you mind if I talk to your coach, your trainer, whoever, your parents? Well, I mean, parents is a bad example. But you have to talk to the parents. But hey, do you mind if I talk to this person? So our athletes, I say, with their coaches and their sport coach, I say, hey, do you mind if I send your coach an update on you or something like that? And you just ask them, and I think everybody welcomes that, right? So, you'll find some people that love the collaboration and some people that don't love it as much in terms of, they don't like to communicate and collaborate. And I just think as a professional, just seek out people in your community that are fun to work with, right? And that want to combine and put their heads together. I think that would be a good approach. So, good. Is that 3?
One more.
Oh, one more. Sorry. All right. What do we got, Matt?
Chad from California. Does the first rib elevate? An orthopedic surgeon in town told me that it is theoretically impossible for the first rib to elevate and get stuck, and has no bearing on limited shoulder motion. How do you get an ortho surgeon to grasp the concept that the first rib stops the motion of the clavicle if elevated when performing shoulder flexion?
This will actually be a quick question. So first rib elevation. It's funny, by the way, that your question is how do you get the surgeon to understand it, because maybe we're not right. I don't know. How about I'll take a stab to start and then you guys can jump in, but I'm not sure the first rib elevates either. We talk about that. It's like, man, anatomically, how on earth does that thing elevate? That doesn't seem to make a lot of sense. What I do feel, though, and we see this quite a bit, is not necessarily that the first rib elevates, but your shoulder girdle depresses, right? And then it appears like your first rib is elevated, but your shoulder girdle is just depressed. And this is actually a good question, especially as this group here, because I think that really changes your perspective on stuff, right? Are you going to go smash it with a barbell? Isn't that something you could do the Google with on the YouTube right now and try to smash your first rib with a barbell, right? Well, the issue is probably not your elevated first rib, it's a depressed shoulder girdle and maybe a side bent thorax, for example. So I actually think that was kind of an easier question, but what do you guys, anybody have anything to add on that?
All right.
Oh boy,
all
right, this is good.
Well, I just, and this is recent, and just kind of, for me, I'm still trying to wrap my head around this, right? Because you guys taught the CRLF test basically here, go down. What happens is, I guess, when the transverse process comes forward, gets caught on the first rib. Can't do this, right? CRLF. But to me, I was like, it doesn't make sense. There can be a lot of things that can limit that motion. Like, why would it be the first rib? But in this MedBridge course with thoracic outlet syndrome, they were showing radiographic evidence that people that were having trouble with that test had a higher first rib.
In comparison to what? How they measure it?
That's a thing I don't know. I didn't read the
Because
story.
if I side bend to the right, my left side is technically higher.
Could be right.
Right? Or if my shoulder girdle is depressed, then my right shoulder. So, I
I have a hard time wrapping my head around it too.
I don't know the answer. We're just kind of like talking. You
Or
know,
can we change that, right?
Whoa.
Yeah. Well, that's the other thing. Maybe it is elevated, but what are you going to do about it? Is that going to
Right.
change things?
So what do you guys think? I mean, if you had hypertrophy of things like the scalenes or something like that, would that elevate it?
Maybe. I'll treat it. Like, I do it in like thoracic outlet patients. I'll treat the scalenes. I'll treat the first rib. It'll a lot of times improve the CRLF. I don't know what I'm doing, or why it's happening, but I'll do it.
Yeah, no, and we work on that quite a bit. I would say I spend as much time on just, thorax positioning more than anything, right? So like, think about it, like scapulothoracic is just the way the scapula sits on the thorax, right? So if your thorax has some anatomical, just, positioning things, and your your shoulder girdle is going to sit a little lower. I tend to focus on that lumbopelvic thorax position, and then just jump right to it. This is the same thing as like talking about doing like a joint mob on a joint, right? And if you're just jumping right to a joint mob without assessing soft tissue and positional stuff and alignment or something like that, and you're just torquing it, or from the strength and conditioning side, you're just slapping mobility drills on somebody and just trying to really just like, crush ankle dorsiflexion or something like that. If you don't know if they're in good alignment or they have just that right positioning in there and you're doing that, you're just cranking on it, you're just kind of like banging your head against the wall quite a bit, right? So I think it's more about just assuring that you have that good position and then reassessing, right? So then reassess it from there, but I don't know.
Yeah, that's a weird one. It's tough.
I don't think we have a definitive answer for you, but I would say keep an open mind, which we've talked about quite a bit. But keep an open mind. Maybe your orthopedic surgeon isn't wrong here. Maybe he isn't necessarily right. We don't have to necessarily convince them of a change of opinion. Maybe we have to take a step back and think if there is some validity to that statement. And I will say I'm leaning more towards the shoulder girdle is depressed versus the first rib is elevated in my perspective. So yeah, good. Student-wise, did you guys learn anything different? I mean, I assume you didn't, but like anything unique that you learned in school recently about this stuff?
Especially with the elevation, that's interesting to me.
Yeah, when I kind of we kind of fluffed over that part of the question.
Yeah.
I don't know if that limits clavicle motion.
It's the last thing I'd go to try to improve overhead motion. It's not like first on the list at all.
Right. It's like 100th on the list.
Yeah.
Of things that could decrease overhead elevation.
Yeah, I agree with you.
I gotcha. I wasn't sure if anything like you guys had anything new that you guys kind of talked about, or just the standard.
We definitely still cover like mobilizations, manipulations, and like multiple positions to, if you think someone's first rib is stuck, this is how you could treat it. But we don't really talk about the theory on why it's stuck or why it's moving, why it's not moving, or what's causing that relative change in motion.
Just more technique based. Yeah.
Yeah, I think we talked about it in terms of maybe some thoracic outlet stuff, and then I feel like we touched on first rib mobilization to improve shoulder flexion, but I never felt like they gave great reasons for why you would do that.
Yeah, it's like on the list, and you're just learning techniques and stuff. All right, I was just checking. I wasn't sure if there was anything new that we're missing on there. So, I'd say keep an open mind. You probably have a bunch of other things to work on there. That's probably like not a low hanging fruit. That's should be something in your clinical focus, I guess, would be how I'd say it. So awesome, nice. Well, another great episode. Thanks so much, guys. Head to MikeReinold.com, click on that podcast link, and you can fill out the form to ask us more questions. Be sure to rate, review, and subscribe to us on iTunes and Spotify, and we will see you all on the next episode. Thank you so much.